Okay. Welcome, everyone. Welcome to the webinar. My name is Mitchell Cronenberg. I'm the Director of Sales and Marketing for the Diagnostic Department here at Haag-Streit. Tonight, we have the privilege to have a presenter, Dr. Paul Karpecki. Welcome. I'm going to go ahead and kind of introduce Dr. Karpecki, and then he's going to go ahead and give his presentation, and we will take questions, I believe, kind of towards the end, I would say, or we could kind of take a break, you know, somewhat in the middle and see if there's any questions and answer those, and then do more at the end, if that sounds okay. Dr. Karpecki received his Doctor of Optometry degree from Indiana University and completed his Dury Fellowship in the Medical Cornea and Refractive Surgery in Kansas City in affiliation with Pennsylvania College of Optometry. He currently serves as the Director of Cornea Services for Kentucky Eye Institute in Lexington, Kentucky, Gaddy Eye Centers in Louisville, Kentucky, Center for Sight in Carmel, Indiana. He's Medical Director of Kepler Vision on the LBRS team at the IOR Partners. In 2017, he completed a full year presbyterianship in advanced retinal disease and at Retina Associates of Kentucky. He also currently serves as an associate professor at the Kentucky College of Optometry in Pikesville. Dr. Karpecki was appointed in the Delphi International Society, which included the top 25 dry eye experts in the world. He co-chaired the Dry Eye Summit for Profession, was selected to TFOS DEWS 2 Diagnostic Methodology Subcommittee, and appointed co-chair for the Tear Film and Ocular Surface Society Symposia. He served as co-chair of the Dry Eye session at the Ophthalmic Innovation Summit during ASCRS and co-chaired OIS Optometry. Dr. Karpecki also serves as the chief medical editor of the Review of Optometry, the most read journal in the profession, and is on the board of the charitable organization Optometry Giving Sight. Dr. Karpecki, I'd like to allow you to take over now and look forward to the presentation.
Thanks, Mitch. Appreciate that. Great introduction. It tells me I need to give you a shorter bio. You did a great job going through it. I have to give you credit. That was really one of the longer bios. So thank you very much. Very kind of you. Certainly want to thank all those who are on the call. I know it's a busy time. I hope your family and all of you are safe and appreciate your presence. I think you're going to find this to be very valuable because we're going to take through an understanding of diagnostics in dry eye disease. This is what I do every day in my clinic. You know, before we got started, we didn't realize we were on recording already, or at least live. Mitch and I were talking about the day, and I had 48 patients today. It was kind of a crazy day. But amazingly, with a really good team, we got done about 4:15, which I don't understand because normally we go till about 6 o'clock. But I think a lot of it is because we follow this diagnostic methodology, which we're going to talk about today. And I think it allows us to really get there. You know, this is the greatest opportunity for eye care. This includes optometry and ophthalmology. I notice there's ophthalmologists on the call too. This is really an important opportunity for anybody who sees patients on a regular basis. According to looking at a publication that asked how many patients had signs, I take that back, how many patients had symptoms when they called in as primary or secondary complaint related to dry eye disease, it estimated the number as 90 million people in the United States. But we know from longitudinal studies, that number is probably 30, 35 million, but it could be as high as 50 million. What's interesting is only about 16 million people are currently diagnosed with dry eye disease if you looked at ICD-10 codes. And the number being treated, about 1.5 million. Now, data in 2020, even though it's been a tough year with COVID, is suggesting about 1.65 million. So we're actually going up, even though we've had quite a unique year, to say the least. 42% of all comprehensive eye exams have a chief complaint or secondary complaint related to dry eye disease. So this is really one of the most important opportunities as far as understanding how to manage dry eye patients. And optometry performs about 88% of comprehensive eye exams, but prescribes about 60% of all RXs for dry eye. That's still impressive, but it means that that number should be closer to 88% as things go forward. Ophthalmologists have to really focus on surgery and secondary care, and some of these areas. Optometry really needs to be looking at this primary medical level, which we're doing to a great extent. If you look at the prevalence of dry eye, I love this study because this is the women's health study that came out about 22 years ago. The reason why I love this study, and I'm being a little facetious, is because they only looked at patients over 55. It makes me think that's the only time you're going to get dry eyes if you hit age 55. But 22 years ago, I think we thought of dry eye as an elderly person's disease, and women had twice as much dry eye as men. I think today we're realizing that's not the case. If you look at this BOSS study, the Beaver Dam Offspring Study, so what they did is they looked at all the patients who were in the Beaver Dam study, which is the longest ongoing longitudinal study around ophthalmic disease that we have today. It looks at how many people develop cataracts, how many develop dry eye. It's been going on for almost 20 years. Well, awesomely, they looked at the children, and they decided they're going to do what's called the Beaver Dam Offspring Study. We're going to see how many of their children have some of the same conditions. So the first one to look at, of course, was dry eye disease. And 3 things came out of it that were fascinating. Number one, there's as much dry eye in the children as their parents. Statistically, 14.1% of all patients in the Beaver Dam Offspring Study had dry eye versus 14.4% of the adults, which is statistically the same. Number 2, the incidence of dry eye between men and women is the same if you look at the population under 34, which is pretty dramatic. And then as you look at perimenopausal, the numbers start to go up. So the 3 key points are: 1, same amount of dry eye as parents. Number 2, we're seeing dry eye in earlier stage. Number 3, men and women have the same amount of dry eye if you look at the population that's premenopausal. DEWS 2 had a wonderful definition that kind of looked at dry eye, and we understand this really well. It's multifactorial, and I know when you see that word, you think confusing. At least that's what I think. And we're going to try and simplify that today. Disease of the ocular surface characterized by loss of homeostasis of the tear film accompanied by ocular symptoms, including hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities. I love this definition because it's taking us to a new level. That being said, I will tell you about a story when I started working in dry eye disease that will, to me, is still fascinating. This was 1997. I'd love to say that in 1997, I knew dry eye would be a big thing in the future, and that's why I went into it, but that wasn't the case. I was working at Hunkler Eye Centers at the
Dr.
time.
Karpecki, for some odd reason, the slides are not moving. Somebody just said that. I wasn't sure if it was.
You know why? It's got something that says resume share. Let me stop sharing for 1 second and then just resume it again, see what happens. That's never a problem.
Gotta love technology.
I love it. Let's try it again. We can always reshare.
There we go.
See that?
Yes.
Okay, so this definition was interesting, and I'm telling you about a story in 1997. Back then, I was just starting getting dry eye, and as I said, I'd love to have known, said that I was anticipating the future. I knew this would be important, but the fact is, I had no idea. I was one of the last doctor to join Hunkler Eye Institute, and as I did, there was only one position, that was to run the dry eye clinic, and so it was either take it or you didn't really have an option. And so at that point, I took it on, and it was frustrating for many years. But I remember someone visiting my office, and he said, "Paul, I'm glad you're in this field of dry eye." And this wasn't an optometrist or an ophthalmologist. This was someone who was in the industry. He said, "I want you to remember the acronym WOMAN, because that's the key to dry eye disease." And of course, as you saw from the Women's Health Study, there's a lot of dry eye disease around women, as we looked at earlier. Let me go backwards, where women had a lot more dry eye than men. But what he was referring to is water, which was aqueous tears. O for oil. We only got into lipids and understanding the oils a few years ago. M for mucins, which we really haven't even focused on to the degree we need to. A for androgens, which we have yet to have a therapy, but we know hormones play a key role. And N for nerves. So here we are, 23 years later, and the definition is starting to cover what this person said 23 years earlier. So it's interesting where we're at. That being said, TFOS DEWS 2 did a remarkable job. And I think one of the problems with these big consensus guidelines is a lot of us think they're going to be confusing and complex and difficult to follow. And if you look at it, there's over 300 pages in the document. So you would think that. but actually they're really representative of a wonderful way to practice, and they're fairly straightforward. For example, you don't have dry eye unless you have signs and symptoms. And if you look at this diagram, it makes a lot of sense. If you have no signs, meaning the cornea has no staining, tear breakup time is good, you express the oil glands, perfect olive oil, and a lot of symptoms, then you probably have something that's known as neuropathic corneal pain or corneal neuralgia, or now it's called COSP, chronic ocular surface pain. That's a person who has pain with no stain. Very difficult condition to manage. Sometimes it's caused by previous surgeries where the nerves are damaged. If you go to the other extreme, where patients have a ton of signs, chronic SPK, severe punctate epithelial keratitis, and they have almost no symptoms, that's a neurotrophic keratitis. That's where something like Sinidgermin from Dompé or Oxervate would be very helpful, as well as Procara or amniotic membrane. So we know that those are not dry eye. So dry eye really requires signs and symptoms, and then you break it down based on the type of dry eye you have. So really, we got to focus on that combination. One of the first things that came out is really differentiating dry eye disease. And that's where technologies like Haag-Streit imaging really come into play. But it's knowing that there are a lot of conditions where patients come in complaining of dryness, burning, foreign body sensation, irritation that aren't dry eye. If you look at the top picture at 12 o'clock, that's GPC. At 2 o'clock, that's Salzmann's nodular degeneration. Medicamentosa at 4 o'clock or 5. Conjunctivochalasis.
Hey, doctor, it's for some odd reason it's not moving forward, the presentation. Yeah.
I've got full, let me try one more thing. That is really odd. I've never had this happen. Let me try just using the Wi-Fi plug-in. Hold on, just hardwire here. Hold on.
Yeah, no problem.
Do you still see my projection here?
Yes, I'm seeing the pictures, yes.
Okay, good. Okay, so these are all conditions, EBMD at 10 o'clock, that all mimic dry eye disease, and there's a lot of them. Did the slide come up now that talks about normal symptoms or symptoms?
No, it's still, it's like it's still stuck on the last that you're picking.
I try doing this. Do you see it now?
Yes.
Let's just do it this way. I mean, it's not going to be a big screen. I apologize for that, but we'll at least be able to show it from this standpoint.
Mm-hmm.
Okay, let's try this. Sometimes, I don't know why, but that can often happen. All right, so we have signs and symptoms, normal osmolarity, minimal other signs. These are just conditions where patients come in with dry eye that don't have dry eye. And that's why it becomes really important to look at the eye, to do good imaging, to be able to see what's going on, to capture the images that are present, to really figure out, what is happening in this disease format. They range from everything from pterygia and epithelial basement membrane dystrophy to conjunctivochalasis, concretions, things like that. In fact, in this slide, did that advance, Mitch?
Yes.
You'll see in some SPK superiorly. This patient had spent 4 years being treated with multiple medications, oral doxycycline, topical cyclosporin. He estimates about $5,000 on treatments. And he came in with a bag full of all kinds of these therapies and scleral lenses that were being trialed. Didn't have to pay for them yet, but he was going to try them out. And I guess I get kind of lucky because he showed signs. If you look at the top corner left-hand side, you'll see a lot of foreign body tracking. So I averted his eyelid, and sure enough, there was a large concretion. I removed the concretion, and all his symptoms went away. So many times we can't just rely on symptomatology. We have to realize that there's more to the disease, including key signs that help us do this. And I think the best way to do this is what's called the TFOS DEWS diagnostic methodology. And as I said earlier, when you get into these consensus guidelines, I think a lot of people get kind of worried they're going to be very complex. In this alone, this one subsection of the document, there were 77 pages. So a lot of us would think, wow, that's too much for me to read. If I asked you, how many of you on this call tonight, we have a large group, read every page of the TFOS DEWS document, I would be shocked if anybody put their hand up, because it just seems like that's a lot to do. And I'm going to take you through 77 pages in about 5 minutes. And when you leave from this, you're going to realize how important and how effective this is in managing your dry eye clinic. It's what I do every day in clinic. So here's the overall executive summary, so to speak, of the TFOS DEWS diagnostic methodology. If you take this with you into clinic tomorrow, you're going to do very well in managing dry eye disease. And we're going to take you through each step. Step number one is looking at triaging questions. And what that means is, isolating patients. I'm going to make this a little bigger for you. There we go. Can you still see that, Mitch? If I make it bigger?
Yes. Yeah, you're good. Yeah.
So what we do is isolating patients who have, known factors for dry eye. So I would ask questions like, how do your eyes feel? Irritated, dry. How do they look? Are they red? I would ask, are you have an urge to use artificial tears, or are you using artificial tears? Other key questions might be, do you have fluctuating vision, or are you noticing vision issues? Because this is really a vision disease. If you think about the fact that the majority of our refraction takes place between our tear film and our cornea, more than the lens, more than the vitreous, than anywhere else. We know how much of a vision impacting disease this is. And then how much time do you spend on digital devices? In fact, Kepler Vision Group, which is one of the PE groups that I'm medical director of, this is what we use on every patient that calls in. And it's amazing how you identify so many patients who have dry eye. The next step in the algorithm, and these are 5 questions: how do your eyes feel? How do they look? Are they red? Blurred vision, urge to use artificial tears, and how much time do you spend on digital devices? Image capture plays a key role. If you want to look at the eye and see their level of injection, you bring this up. Every patient is conscious of the fact that they have red eyes. If they do, they know there's injection there. And there are good products like Lumify now. I mean, I spent 20 years telling people never to use redness removers. And now we talk about the benefits of an alpha-2 adrenergic receptor in Lumify. And in that case, you're constricting veins. And so there is an advantage to that drug compared to constricting arteries. But you can definitely tell the difference and show patients as they improve over time. So how do your eyes look plays a key role. Then you want to look at predisposing factors. Are they a smoker? Are they on antihistamines? Are they contact lens wearer? Have they had refractive surgery? You can go through a whole list. They have systemic diseases like diabetes, thyroid disease, etc. Those are your risk factors. Now, knowing they had the triaging questions and risk factors, it makes sense now to go ahead and do a dry eye diagnostic workup. Remember, in order to have dry eye, you have to have symptoms and signs. If you just had symptoms with no signs, that's a neuropathic condition. If you had signs with no symptoms, that's neurotrophic keratitis. So you got to have both. So first thing you want to do is have a questionnaire. My favorite 2 questionnaires are the DEQ5 and the SPEED questionnaire. That's where I would focus on. Have the patients do this before they come in, have them do it while they're waiting in their car, whatever it is, but just have that done ahead of time. It gives you a score. If the symptoms are there. You don't have to take more time than that. You might reiterate a few things in it, but that's about it. So DEQ5 and SPEED are my 2 favorites from that list. Now you've got symptoms. So now you have to have a sign. TFOS DEWS 2 recommends you do one of these 3 tests. I'm going to recommend 2. I'm going to be a little more aggressive. I'm going to say you got to do at least 2. You have to do breakup time. If you have a non-invasive device like an Oculus or something like that, it's fantastic. But if you don't, even just breakup time will work well. You have something like a Haag-Streit imaging system, you'll be able to capture that easily. Osmolarity would be another recommendation. And then ocular surface staining, corneal and conjunctival staining. You only need fluorescein. I know a lot of people say, shouldn't I use lissamine? It's much more sensitive. Well, we had a shortage of lissamine a few years ago. And in an effort to see as many patients as I try to see in a day, we said, okay, we're just going to use fluorescein with a cobalt filter. And I will tell you, I can see almost as much conjunctival staining. So we just use fluorescein and we look for corneal and conjunctival staining. And guess what? Just doing breakup time and ocular surface staining, that meets the DEWS 2 diagnostic methodology for signs. If you're really into dry eye, you probably got to do osmolarity. It's an extremely accurate test. It's one I couldn't practice without in my dry eye clinic. But I think if you're not dedicated fully to this area of corneal disease, then I think you just should be doing at least your breakup time and ocular surface staining. So here's osmolarity. It is one of the most accurate tests you're ever going to find. Is an 87% positive predictive value. Patients who have dry eye, you can't fake it. They end up getting all kinds of instability and numbers above 300. Patients, as you see in the top left here, who have no dry eye, all stay very consistent on every measurement. So let's get into a little bit of tonight's presentation too, which is how does imaging help? And I get this question almost every time I lecture. Paul, I'm going to build a dry eye clinic. what's the first piece of equipment I need? And of course, they think I'm going to say osmolarity, as I just said. And I do believe in that technology. I think it's phenomenally accurate. And it helps me throughout my day to know who has dry eye and who doesn't, what level they have. But my true answer, you need an imaging system. I can't remember 3 months ago if they had grade 3 staining, what that looked like. I could have grade 3 staining that's in the inferior cornea. I could have grade 3 staining that's confluent. I could have patchy staining. All of that is completely different. But if I pull up an image on a Haag-Streit imaging slit lamp, which is no more expensive than getting any slit lamp, which is what makes it so amazing. And I look at their picture, and then I look at their picture today, I know exactly how much they've improved. I know where they're at. I can take an image and I could show patients just exactly how well they're doing because I'm able to, show them the pathology. And a picture is truly worth 1,000 words. I know it's an old adage, but when you can show them their own eye and explain what is happening, it's instant for them to get there. So the slit lamp basics, not to go too much into this, you know what that looks like. It's how it takes things that you can't see, as you see in the upper image there, and then makes them incredibly visible by how you change the optics related to it. And we've all known for years there are no better optics in a slit lamp than a Haag-Streit system. It has always been the gold standard, the highest level of anything we can have. But now that they have an imaging system, it takes us to another level. It's kind of like this. Your lighting makes a huge difference. The image on the left, and I know you've all looked at slit lamps where you bleach the image. I do it too much myself. You couldn't even tell the detail. But by creating the right light setting, you're able to tell that there's an entire pattern that takes place on this crystal glass. They have the ability to change not just a few amounts, but huge amounts of imaging levels, meaning the beam size, focusing it, increasing the intensity, all of these little tiny details you don't think of make such a huge difference. As you get to know these systems, and I get this question a lot too, is how do I know which system to utilize? The Galilean slit style microscope allows us, that's the BQ900 and the BP900, allows a splitting of the image. And so that creates an optical design where you get maximum capabilities. And the BI900, as you see from there, has less in terms of the amount of lenses that allow for it, but still allows for optimal optics amongst things we have. So I've got this in my office. I think this plays a really key role. And you can look at each one. And if you're going to be like an imaging expert and you're going to be documenting these things, then the BX900 might make sense. But for most of us, it's BQ900 and BP900 in most cases. You can even get away with a BI900, which gives you all the essentials that are there. And all of these use LED illumination. They all have imaging capabilities built into them. So a lot of the mean average of what works might be a BP900, but you can get away with either one on each side depending on what level you want to get to. So LED is so key. And you're looking at a slit lamp technology, especially for ocular surface disease, looking at SPK, you have to have LED illumination. It's not, no more filament technology. That just does not allow you. In fact, what this allows is uniformity. It gives you the sharpest slit image ever. Have you ever had times where you're looking in an anterior chamber and you're trying to tell, well, I can't quite see the cell and flare, and then you move over and you kind of do? That's never an image issue here with the Haag-Streit. You will see it the moment you focus on the anterior chamber because of that sharp slit that takes place. The best images I could ever show you of this is below. If you look at LED illumination, you'll notice how uniform that pattern is versus filament or tungsten illumination where you have natural bands that take place. And this is one of the keys as you're looking at imaging on the ocular surface. Continuous live view video. I love being able to show patients that when I express their meibomian glands or when I do a debridement of their eyelid and my debrider is filled with keratin and meibum all over it. Patients are amazed at that. And it allows them to continue to come back to my office or your office. They're not going to go anywhere else after they see one of those videos that you've been able to capture. There's also still photographed with flicker options. You can migrate through each image, and then a history trigger. You can hold it down and take a series of pictures and then keep the one that you want. On-off button, no surprise there. But I love the, not only the automatic ODOS detection, it automatically shifts to that. I can't tell you how many times I've been doing presentations where I've tried to find the same eye and I just mislabeled it. With older technologies, this allows for all of that to happen. You have two illumination controls, background illumination and slit. You're amazed at how having both of these can really optimize your images. And that makes a huge difference. And then that capture button is that big bar. So if I want to capture an image, I just have to press anywhere on there. Sometimes I've got one hand and I'm doing a punctal occlusion. I have that ability to just push forward. I can actually get my imaging at the same time. It becomes incredibly handy. And then you put all this together and you're able to capture the images that you need to be able to make the diagnostics. And I talked earlier about capturing the best image you can for the patient. And all of that goes into the diagnostic component. If I'm able to show, the breakup time and image it, if I'm able to show staining of the conjunctiva and of the cornea, makes a big difference. And I will tell you that with this technology, you can image the conjunctiva better. You don't even need lissamine green because of the illumination, because of the optics, and because of the way that they all come together. Another really important thing when you're managing dry eye disease is to have a yellow filter. Now, the Haag-Streit imaging system has that built in, but I do this all the time when I have visiting doctors. I had a visiting doctor today. I don't have as many now with COVID, but there was a doctor with me today, and I was showing the blue, and you could barely see the staining. And I threw in the yellow filter and it just blew up. It lit up like nothing else. And that's what you need to have for capturing the full image. And then that's what you want to look at 3 months later or a month later to be able to tell how much that patient has changed because of your treatment plan. The BQ900 and BP900, and again, I kind of told you my lean is towards the BP900, but you can look at all of them, have that yellow filter built in, which allows an instant one button contrast appreciation, and have fun with it. I mean, put it on the eye with the normal blue and then throw in that yellow cobalt filter, and all of a sudden you'll see things you never could see before. A patient that looks like this, where you can't miss the imaging because of that filter capability. And prior to this, it was really hard to see the staining. I know that sounds bizarre when you see how much is here. And maybe I could see the lower part, but I couldn't see the central. And that was where the real difference comes in. You want to look at tear meniscus height, tear breakup time. As you can see here, I'm imaging the tear breakup time, and you can do this with a video. And that's one capability here. So let's take a look at the rest of the DFOS algorithm. I started with, I know there's a lot of information, but I'm going to reiterate it for you. I began with triaging questions. How do your eyes look? How do they feel? Urge to use artificial tears? Are you getting fluctuating vision? And how much time on digital devices? Anything over 2 to 4 hours is significant. We looked at predisposing factors. This patient has thyroid disease. They're on antihistamines for the last 6 months. They have, borderline diabetes. They've had surgical procedures, and they're female. All of this kind of lines in to a greater chance. Then we go ahead and do symptomatology. We do our DEQ5 or a speed. We get a score of 22. Next step is to look at a homeostatic marker, osmolarity, tear film breakup, which we just had right here, or corneal staining, which we had here. So let's do at least 2 of those. Say we have corneal staining and a rapid breakup time. The only problem with these 3 tests, as good as they are, is they don't necessarily tell me the type of dry eye. And the treatment for the dry eye is different depending on which type you have. The good news is there's only 2 types of dry eye, although I will tell you, I think there's a third. I think aqueous deficient dry eye has a mucin deficient component as opposed to an aqueous deficient component. But let's assume there's only 2 forms, aqueous deficient and evaporative. Evaporative happens later in the day because the tears evaporate because the meibomian glands don't function well. Aqueous deficient, like Sjogren's syndrome, is the fact that you don't have the bulk of your tears. So, and that's going to be related to arthritis and lupus or primary Sjogren's or just KCS, and that's where your aqueous or mucin glands aren't working well. Conjunctival staining will help you to determine a mucin deficiency. So we've got 2 forms. I can't treat them the same way. I treat them very differently. So how do you differentiate which one it is? That's called subtyping. And that's this section here. It's either evaporative or it's aqueous deficient. So if it's evaporative, what do you do? If it's aqueous deficient, what do you do? All right, let's take you through that. So for evaporative, you express. It's that simple. You've got to find a way to express meibomian glands, whether it's your fingers, Mastroda paddle, MGE, meibomian gland evaluator, dual paddles. But if you don't see what's coming out of the meibomian glands, there's no way to know if they have evaporative dry eye. I mean, I shouldn't say that. There are ways to know. If you had scalloped eyelid margins, tons of telangiectasia, there are kind of notching of the eyelid. I guess you have an idea. But for 70+% of all patients, you wouldn't know unless you pressed on the meibomian gland. So for the large majority, you have to express glands, and you have to do it every single day and on every single patient. I'm not exaggerating. There's studies that have been done by Priya Gupta out of Duke that showed significant meibomian gland dysfunction and atrophy in children between age 4 and 17. And it affected 42% of the patients they studied. So this is something I do on everybody. It takes 5 seconds. You express the lower nasal to central glands, and if it comes out like olive oil, you're clear. If it's gelatinous like this, that's level 1 of dysfunction. Actually, we go from level 3 being good olive oil, so that's 2. 1 is toothpaste, and 0 is no expression. I would know right away what's going on. And this is a good example of what happens functionally. Here's a patient that has a 2, maybe a 3, because it's a little yellow or whitish. 2, 2, maybe, no, sorry, 2, 2, 1, 2, 2, 1. So 3 is normal. You want to get 3, 3 every time you can. That's olive oil. 0 means nothing. And then how do you know if it's aqueous deficient? Look at that little tear meniscus. Yeah, there's a lot of staining. I see that, but that tear meniscus height. And the question is, how do you measure that? Well, you don't need to. If you take a picture with your Haag-Streit imaging system, you're going to capture it extremely well. And a lot of people say, well, do I need to measure it? Do I, if I look at some of these devices, I can measure the amount. I don't know. I mean, yes, anything less than 0.02 microns is considered a low tear meniscus. 0.2, microns or less. I watched an award ceremony that was given about 7 or 8 years ago to a nurse who received the highest award, the Presidential Medal of Honor. And you don't get many of those given out, except for people who are like heroes in, the wars and other things like this. This was a nurse at a neonatal center. And she got this award, and they were telling all these stories about her of how she saved at least 1,000 babies over the course of her 35-year plus career. And there was one case where, and in this high intensive care unit, every single neonatal child, because it was really serious illness children and really preemies, et cetera, had their own RN. So every one of them had a baby one-to-one with the nurse. And there was a story where she had come in as a supervisor and noticed this one baby and walked directly over to her, took the baby out of the incubator, held the baby up, looked at her back, saw modeling on the back, looked at her foot, saw crystallization around an injection. They had taken a blood sample out and crystallization around it, probably strep viridin, said, oh my gosh, this child has sepsis. Let's get her on IV stat. And the baby survived. And the nurse who was sitting with her, who told the story, said, this child had perfect vitals. Blood pressure was normal. There was no temperature. She was eating normal. She was breathing normal. She was crying appropriately, not excessively or not, sleeping normally. And they said, how did you know? And the supervisor nurse said, I just know what normal looks like. And I thought, that's a fantastic answer. I think we don't have to measure so much. We have to know what normal looks like. I know this is abnormal. If I looked at every normal young patient, I would know what a proper tear meniscus height is. So I would know when a scant one shows up. And I think that's all you need to do. And imaging allows you to do that. And why is this important? Well, the treatments are different. What I'm giving you here is my algorithm, which I've developed over 22 years. I've realized that when I'm treating an evaporative form of dry eye, I have to focus on inflammation and tear volume. So if there's staining, I'll start with a corticosteroid. I may use omega fatty acids in almost all cases, especially GLA-based, omega fatty acids like hydro. I have really good success with that. Autologous serum comes into play, amniotic membrane, cytokine extract drops, Acthar gel, et cetera. That's all inflammation. I plug 90% of all the patients with an aqueous deficient dry eye, but only plug 20% of those who have an evaporative dry eye. So knowing what to do, take that back, knowing the diagnosis, whether it's evaporative or aqueous deficient, becomes incredibly critical so that you know what to do in terms of managing them, whether it's brimonidine for redness, artificial tears, punctal occlusion, et cetera. And if I go to evaporative dry eye, I realized very quickly that I've got 4 elements to treat this disease. So this is why I have to express my meibomian glands. I have to realize, see what's coming out of them to understand what type of dry eye it is. I also love, this is a little one of my algorithms, but I love this algorithm of mine because I use it to teach patients, what's going on. In fact, I start by saying, your type of dry eye has 4 elements to it. And 22 years ago, when I started in dry eye, we were only treating the one on your far right. We were treating the tear film. We put artificial tears in your eyes. And then we wondered why you didn't get better because we were missing the next 3. And then about 18 years ago, cyclosporin was approved in a Restasis form. We finally had a drug for treating inflammation. Although it was effective, it only worked around 35–40% of the time for evaporative dry eye because we weren't treating the other 2 things on your left, the bacterial biofilm and the obstructed glands. Today, we treat all 4 elements and our success rate is over 90%. But if you miss one of the components, you're going to realize your success drops dramatically. So if I had like a mild dry eye that was evaporative in its diagnosis, I would treat the patient with a hydrating compress and lid debridement in the office. I would use a surfactant cleaner like an OcuSoft cleaner. I might put them on cyclosporin and omega fatty acid, and I'd use a lipid tear. If I had a severe form, ocular rosacea, very few glands left, patient has an osmolarity of 335 because of it, I would talk about thermal pulsation techniques, your eye luxes, LipiFlows, TearCares. I would consider, doing an blepharoexfoliation. I'd put them on a steroid and doxycycline to try and control the level of rosacea and inflammation, and then move them to a long-term maintenance. And for tear film, I'd use an aqueous deficient, I'd use an osmolarity lowering tear like TheraTears. So my point is, whether it was mild or whether it was severe, I didn't miss one of these 4 components of evaporative dry eye. I made sure I hit every one. It just didn't require as much of an aggressive therapy if it was a mild form compared to a severe form. And that has really gotten us to a really high level. But all of this starts with understanding the DEWS-2 diagnostic methodology. Begin with appropriate questions to identify dry eye. How do your eyes look? How do they feel? Fluctuating vision, urge to use tears, how much time on digital devices. Look at risk factors like autoimmune disease, medications, previous surgical procedures. Look at female smoking, environments that are dry. All those things play a key role. Now you have a good chance of realizing this is dry eye. Do at least one questionnaire like the SPEED or DEQ-5, one homeostatic measurement, tear breakup time, which you can image really well, or osmolarity or ocular surface staining, which includes cornea and conch, which you can greatly image, which makes a big difference, especially with the Haag-Streit imaging system where they have the yellow filters built in, et cetera. And the capturing rate based on illumination is amazing. Now I've got this wonderful image. If there's any problem with these 3 is it doesn't tell me the type. So in order to know if it's evaporative, I express in the meibomian glands. And I usually show patients the pictures so that they can see why they're not normal. And if a normal meibomian gland expression happens, like olive oil coming out, then I look at the tear meniscus, which the fluorescein was already in the eye. And if it's extremely scant, because I know that's not normal, then I know it's an aqueous deficient form of dry eye. That's 77 pages in that last 1 minute I just covered. Although, of course, you had it for 5 minutes beforehand. But that's 77 pages you got. And I believe it's the best algorithm for diagnosing dry eye that we have. It's got over 800 references supporting what we just talked about. It's what I've been doing in my clinic for over a decade. And it works. Imaging is the key. If you can show a patient a picture and you can look at it and say, I'm really concerned about what I'm seeing here. And if I don't treat this Demodex blepharitis, you're going to lose your lashes, your glands are going to atrophy. All those things happen. I think I usually get a very high compliance rate, but without a picture, things don't get there. There's no way I can remember what their staining was if I don't capture it and look back on it after I've started my treatment. And we already talked about treatment, whether it was aqueous deficient right here, or whether it was evaporative. The treatments are very different once you get your diagnosis. Keep in mind, this is a progressive disease. Once any immune-mediated disease progresses. So the goal in managing patients with meibomian gland dysfunction and dry eye disease is to identify it early and treat it. If you catch them before it tips into adaptive immunity, you may have saved that patient from being on drops for the rest of their life. And that's why imaging it while they still have very few symptoms is so valuable. If you grab this Haag-Streit image and you show them, whether I talked about blepharitis or staining or, the rapid breakup time or the expression, you're going to convince them a lot quicker that they need to do something about it. This slide here shows one of the arms in the original cyclosporin trial for approval of Restasis. In one arm, they used 0.05% cyclosporin. In the other arm, they used one of the best artificial tears on the market at the time, called Endura. Almost 40% of the patients on artificial tears progressed, increased, take that back. The patients on artificial tears had a 40%, 39.1% increase in T cells. Now, there was a proportional group that was about that size also that progressed. The Rouse study showed 42% patients advanced. 32% in his most recent trial had moved at least one level of severity. But there was a 40% increase in T cells, meaning that if you don't treat the disease, this disease progresses. An example of an immune-mediated disease before we start taking questions, and this is an extreme example, I know, but it's anaphylaxis. If a person eats shellfish every day for 50 years and never has a reaction, and on their 50th birthday, they decide to eat some shrimp, and they get hives over a third of their body. It's pretty severe anaphylaxis. What happens if they decide to eat shellfish the next day? Does it take 50 more years to build up? No, in fact, the next day they probably can't breathe. That's an example of immune-mediated or of adaptive immunology. The T cells become primed. Any disease where that happens, the T cells have a memory, and so they know to respond to the next insult the same way. So if you drop out of contact lenses from dry eye and it took you 20 years, and if you fix that dry eye and they go back into contact lens, it doesn't take 20 years to drop out again. If they've got immune-mediated disease, they'll drop out within a few weeks. That's why it's so important to treat early in the disease. And the only way you're going to do that is by early diagnosis. This is the most common condition we face. We have a wonderful practical way of diagnosing dry eye through the TFOS DEWS2 algorithm. Haag-Streit imaging provides practically everything you need in that algorithm in order to make your diagnosis. And because it's progressive and chronic, it warrants an early acute diagnosis so you can have an appropriate patient management plan that helps prevent immune-mediated disease long-term. With that, I'm going to open it up for any questions that you might have. Mitchell, I'll pass it to you, and let's see what we've got.
I'll let you know if any questions pop up here. Thank you. That was a great presentation. We really appreciate you taking the time tonight to go over this with us.
Well, I'm honored to. I think it's such a valuable opportunity. And I think people think that that algorithm is going to be really complex, and it's a wonderful, simple way of managing dry eye. I mean, in my clinic, I measure osmolarity ahead of time. I have my symptom selection there. When they come in, we put, I express through my Bowman glands, we put fluorescein in, we look for conj and corneal staining, the tear meniscus height, and then we have our diagnosis. And a lot of people come into my office and think, I can't believe that's all you do. Don't you have something more complex? No, that's what we do.
We have a question here from Dr. Greg Nixon. Do you use the Korb MGE device to quantify expression?
Hi, Greg. Great to have your question. Great to have someone of your notoriety in Ohio involved. Thank you very much. So, there are many options to express. You have the Mastrota paddle from OcuSoft, which is the one you saw in that image where I put, the device behind the eyelid and then pressed with my thumb on the outside. You have a double, like Bruder has a double one. TearCare has a double divider. The Meibomian gland evaluator is one where it's a blue device, has a little pressure. And what's cool about the Meibomian gland evaluator from Don Korb is that it has the exact amount of pressure that a blink would provide. So whatever you get from pushing that on the lower eyelid is what your blink should do, same amounts of pounds per square inch, to allow oils to come out. So what's the most accurate? In a real world scenario, with a patient who comes in who's a contact lens wearer, everyday patient, the Meibomian gland evaluator device is going to mimic exactly what should happen with a normal blink. And that's the way we get oils. When we blink, the oils secrete. So that's the most accurate. My clinic is 100% referral based. I don't get anybody who walks in. In fact, if you tried to walk into my clinic, you'd have to wait in line for all my colleague referrals, which would be about 5 or 6 months. And I'm not saying that to sound like we got something special. It's just that that's the time. That's just how much demand there is for managing patients with advanced ocular surface disease. I have over 600 Sjogren's patients in my clinic. So 34 graft versus host disease patients. So it's such an advanced group that the wait is a while. So I don't get anything from the MGE with that patient population. So I use the paddle. So the question is, what do you use? Depends on the type of patients you're seeing. Everyday patients, MGE evaluator is the ideal way to go. Dedicated to dry eye, seeing more advanced patients, referral center, secondary care, you probably need a paddle. Good question.
Yeah, we have another question here. You mentioned a third general type of dry eyes as mucin aqueous deficiency. How would you treat it?
Great question. I didn't put my algorithm up for that, did I? I love who asked that. I'm impressed.
Dr. I might say this incorrectly. Sorry, Dr. Al-Saidi.
Well done. Well done with this question because I hinted at it, but I didn't get into it. So I'll give you a little bit of my favorite secrets here. Mucin deficient dry eye is a very significant form of aqueous deficient dry eye. The way that you diagnose it before I talk about treatment is you just use ocular surface stain. You put fluorescein in, but rather than looking at the cornea where you typically see, thin tear meniscus and patchy staining, which indicates your aqueous deficiency, you look specifically at the conjunctiva. You have to have a yellow filter like in the Haag-Streit imaging of that level. And as you look at the conjunctiva, it will light up. So anything above grade 2 staining, which is confluent or significant conjunctival staining, indicates to me I've got a mucin deficient form of dry eye. I don't make things complex in my clinic. I used to 20 years ago. I made it so complex. I don't know how anybody could have followed anything I lectured on back then. Now it's gotten so simplified. And we do the same thing 40 to 50 times a day. Literally, I had people visiting me today and they're like, you did the exact same things 50 straight times. I said, yeah, you don't need more. It just takes care of every diagnosis. So I look at the staining. If it's primarily conjunctival, that's a mucin deficient component. So my treatment's not too different than the aqueous deficient you see here. But what I will show you, if I can leave the Q&A, let me go to it. So I'm still treating inflammation, but I'm focusing on mucin on the right side. So the only differences are, so on the Flarex works extremely well. For some reason, it has gene expression as a steroid. It's very effective against specific gene expression on the ocular surface. So if I had to use a steroid and it wasn't too expensive, I do that. For most dry eye, I use a little lodiprednol, but I would use Flarex specifically. I would do 4 times a day for a week and then twice a day for 3 weeks. Both cyclosporin, whether it's Cequa or Restasis, have been shown to improve conjunctival staining. So longer term, I would use that as well as lifitegrast. Don't get away from that. That one has 2. Cequa has been shown to do it within 2 months. That's the fastest I've seen in a clinical trial. Lifitegrast at 3 months. Cyclosporin, Restasis about the same time. We talked about Flarex. Serum will work as well. And I like HA products, so hyaluronic acid products. To the right side for mucin, the thing that I have found to be the most effective, so here's a secret that few people know, vitamin A ointment. If you put a little vitamin A ointment in the eye before going to bed, and of course I don't like ointments during the daytime because they blur your vision, but before going to bed, as long as you don't put a lot in there so it ends up in your hair and pillows, you will have an amazing response on the mucin glands within about 2 months. So control the inflammation, find a good vitamin A ointment. The best I've ever seen is out of Canada. I know it's hard to get. It's something called Ocunox. It's a pure vitamin A form. Best in United States is called Vita A. You can get it on Amazon over the counter. It's a unique product, but it works extremely well. If they have red eyes, use Lumify. An alpha-2 adrenergic receptor agonist will help oxygenate that ocular surface. And you'll actually see those patients do better when they're on that product with a mucin deficiency. As I said, I spent 20 years telling people not to use Visine, not to use Clear Eyes, and we were right. And those are artery constricting, ischemic inducing drops. That's the last thing you want. And here I am recommending a redness reliever known as brimonidine, but it's a vasoconstrictor on the venule side. So you increase oxygen on the surface. Very different. So that's the only differences. HA tears, like Oasis would be your best example, and there's others. Vitamin A ointment at night. Control inflammation with a steroid first, such as Flarex, then move to lifitegrast or cyclosporin long term. That's my algorithm for mucin deficient dry eye. Glad you asked. I wouldn't share it unless someone asked.
Do you anticipate to see an increase in dry eye patients after, I don't know if you can still consider quarantine or COVID, due to a lot of people working from home, being in front of a screen for 8+ hours a day? Yeah.
Great question, Mitch. That's what we're seeing. You know, it's interesting in my clinic is we're seeing a significant amount of dry eye increase. There's no doubt about that. But so are my colleagues. You know, I don't really want to see primary dry eye. In fact, my goal is to share everything I know so that we get less patients in a clinic like mine, because by the time they get to my clinic, they're at the end, and I'll improve them, but it's not to the level they would have been had they been managed earlier. And so I love sharing these things because they apply even more so at an earlier stage. When I talk to my colleagues who are managing, you know, primary dry eye care, they're telling me they have never seen so much as they're seeing today. And we're seeing more than ever too. What I'm really seeing though a lot of is procedural drive. I've seen patients coming in wanting, you know, more iLux, more LipiFlow. Not that they're saying those things, but needing more of those, more IPLs, more blepharal exfoliation. So when I say this is what you need to have, low light level therapy is a wonderful treatment too. That's less expensive than IPL. When I recommend those, I used to get a dropout of maybe 1 out of 4 that said I'm at the end. So most patients are going to do what I say. I still had 1 out of 4 that said I can't afford it or I won't do it. Today, it's probably 1 out of 10. I mean, I don't know if they've saved more money, stimulus, they haven't done anything for 9 months or whatever it's been. They're coming in now. They're more willing to do more things. So I think we're getting more success because they're more willing to do the advanced procedures.
Can masks cause dry eye, or is from people wearing them?
Oh, great question. Yeah, in fact, there's a term called MAID, which is mask-associated dry eye, because it's so common. I would say that the number of hordeola and chalasia that we have seen since people have been wearing masks, which really is about our only protective mechanism that's been shown to be effective. Distance, time away from people who could have COVID, and masks. That's the only thing that's worked until we get a vaccine. So we have a lot of masks. I've seen a 400% increase. We actually looked at the number. We said, okay, how many ICD-10s have we had since May? Because we didn't do much in, April. I think we had to cut off in April, but we didn't really see patients at the beginning of April. But still, we went from April till, we ran this like mid-November, right before Thanksgiving. So between that and November, we found the number of ICD-10s for hordeola and chalasia in my clinic were 4 times more than the entire previous year. So I think that's all mask related. I think the air is going up and is causing something affecting the caps of the glands, and they're getting a lot more hordeola.
Are you billing? We had a question if you found that the imaging system works with your EMR, and are you able to bill for the images?
Oh, terrific question. Absolutely. One, it's completely compatible with EHR. I mean, immediate uptake. We have it, every single image right into our EMR, and we use a common one. So I think it would apply to almost everyone out there. So that part's no problem. Number 2, yes, don't forget to bill anterior segment imaging. I mean, you've taken the picture. You're going to get reimbursed around $16 to $18. Doesn't sound like a lot, but if 1/3 of your billing went through, you'd pay for your Haag-Streit system in like 3 months. So don't forget to do that. I think the problem is people don't do that. They kind of take their images and are like, wow, this is so helpful. It just convinced the patient they need treatment, and it's given me, you know, something to look back on to see how much I've improved them. And bill, that's an anterior segment photograph. If you took the picture, it's warranted. They have disease and you're going to get covered. We get reimbursed 38% of the time we bill for anterior segment imaging. You're thinking, wow, that means you don't get billed 42%. Yeah, but that 38% pays for the entire system in 3 months. So, and it's legitimate. And should we fight the other, 60 or 72%? Nah, no need to.
Another question pop up here. Do you charge for osmolarity test, and which type, if any, does high reading indicate?
I love this. Great job, Jeff. So yeah, we do charge or bill for osmolarity. So we have a $25 charge, which we typically insurance will cover. Insurance will typically cover 75% of all the osmolarity, 78% we bill. So that's good. It goes to insurance, patient doesn't pay for it. But we still do an ABN real quickly because there's those where it doesn't get covered and they get charged $25. Most patients say, oh, it's worth it, because for me, it's so valuable to have that information. 300 and between 280 and 300, both eyes within 5 units, 5 milliosmoles per liter means you don't have dry eye. In fact, you only have a 3% chance. Between 280 and 300 and both eyes within 5 units. That's where it's so valuable. If they're between 300 and 315, that's mild dry eye. 315 to 330, moderate. 330, and of course, use the higher reading. You don't need both to be above. 330 and above, severe. And that's very, very accurate for the disease. Now, you have to have a good trained technician. Their little pen for a tear lab, the reading component's on the bottom, but it looks like it should be on the tip. So if you poke the tip in, you're going to get you're going to get epiphora, and you're going to get an abnormal osmolarity. You have to set it on the tear meniscus. And I don't think the company has trained that very well. So you have to have a good technician doing it, but it's incredibly accurate when you do.
We had a question, any way to view the webinar again at a later date? Yes, we will be, I'm sure we'll be reposting this multiple times to LinkedIn. You can always reach out to Dr. Karpecki or myself, and we can always email it to you, or just give us a call. So another question, I guess, how do you advise pediatrics children? Are you seeing an uptick in dry eye in children, and are you advising parents to limit, obviously, screen time, things of that nature to?
Love this question, because that's where imaging is so critical. If you can't take a picture of the expression, of the missing meibomian glands, of the tear film, of the staining, parents are skeptical of, well, that's my child, but she's normal or he's normal, and they all do that amount of digital device use. But when I show them a picture on this imaging system, and you're more likely to get a really good picture with this system, the Haag-Streit imaging, and I say, I'm really concerned about what I'm seeing here. The minute you hear say the word concerned, if a patient or a parent knows the doctor's concerned, watch how they move up towards you to look at it. They sit in the front of their chair. They get a little white if it's the patient. I mean, it is dramatic, the word concern. So I use it because I am concerned. I know what's going to happen if we don't treat this, especially to a child, how many years they still have. So I say, I'm really concerned about this. And I explain, the congested glands. I can explain the atrophy on mybography, at this age already having. So picture is absolutely critical. And then I do know the reason they're getting this is digital device use. And I empathize. I say, I understand. I have 3 children. They're doing all their schooling right now from home on digital devices. We can't get away from it. It's not an option. But I do tell them that because of the fact that children all of us don't blink when we're on digital devices, our oil glands aren't producing the oils we need. We're developing dry eye. This will become a chronic condition over time. We have to try to limit it when they're not in school time or specifically doing things they have to do. And I find patients, because they've seen the image, they know it's their child's image, are much more likely to listen. I also think high visible energy, off of those screens plays a key role in their sleep patterns and their agitation. And I don't know if it's going to affect their macula long-term. Who knows? 50, 60 years, probably, but we don't know. No one can do a study that long. But we do know that it does affect sleep patterns and agitation and dry eye. So even for that reason alone, I think it's real important that, we use eye safe where we cover the screens, or blue high energy visible blocking lenses and our spectacles, or whatever. I think all of those are opportunities to educate.
I know it's getting a little late here on the East Coast. If there's any more questions, we'll be more than happy to answer them. If not, we could stop here. I'd like to go ahead and thank Dr. Karpecki once again for presenting tonight. I think we all took a lot away from this presentation. I also want to thank everybody for attending as well. Please stay safe, stay healthy, and we look forward to doing more of these in the future. Anything last things you want to add, Dr. Karpecki?
Mitch, thanks for being such a great moderator, setting this all up, the great Q&A. I just also want to thank all those who participated. We had a large group. It says a lot about you and your dedication to continuing to advance. I thank you for making time, especially right now. Stay safe. Happy holidays. Happy Hanukkah. Merry Christmas. Thank you for being part of this.
Thank you. Good night.